Hello, hello, everyone. Welcome. This is the final showcase session, which is designed to give an opportunity to interact with experts here using nanopore sequencing at the interface of public health. Each of our speakers will provide a brief overview of their research and interests before joining in a general discussion, where we'll be inviting your questions. And this is an on-site only session, so we'll be taking questions from all of you here on the floor. So I'm now delighted to kick things off by introducing Lara Urban. In 2022, Lara obtained a Helmholtz Principal Investigator Grant to start her own research group at Helmholtz AI Institute as a faculty member of the Technical University of Munich. Her research group now leverages genomics and AI to better understand One Health. Take it away, Lara.
Thank you very much, Aaron. It's great to be here. So I would like to talk briefly about how I see public health actually in the angle of a One Health issue. So I'm not only here as a research scientist or PI interested in One Health research today, but also as a member of the German governmental One Health Council, thinking about how we can actually implement One Health policy. So One Health describes that all the health on our planet is inextricably linked. So it extends the public health concept to the health of all other organisms on our planet and also to the health of entire ecosystems. And I would really argue that with all the advantages that we get from nanopore sequencing, so that we actually get genomic data, we get long reads, we get genomic data like really for a cheap price, on-site, wherever we want around the world, and in a really fast way, we can leverage that to understand genomics across these different health systems and to really connect them with each other. So I would also like to point you to our recent review on how we can use what we call real-time genomic technology to better understand One Health. And in my group, we really tackle a lot of different questions across these different health systems using nanopore sequencing technology. I just briefly would like to point you to Ella's work, who is also a medical doctor who has just established nanopore sequencing in the clinic for antimicrobial resistance monitoring, where she showed that it's actually sometimes working better than clinically established approaches. But now, actually, if we go away from just public health, right, and think about how can this have an impact on One Health policy, this technology. We can, for example, think about monitoring the environment. So here I'm showing you that we can really robustly assess the air microbiome and very location-specific air microbiome in an urban environment. So we can see the impact, the anthropogenic impact on the environment and directly assess human health consequences, for example, through antimicrobial resistance genes that we find in the environment. But we can take that a step further and we can make use of the very unique data modality, so the squiggle data that we get from nanopore sequencing, and try to infer other important features, such as, for example, if a pathogen that we detected is virulent, and we are having some preliminary results here that show that from the raw squiggle data, we can actually say how virulent a specific pathogen was. And we are currently in the process of making use of all these advantages of nanopore sequencing, especially of the low investment costs and the portability, to establish One Health frameworks in countries such as Zambia in collaboration with local researchers, as well as thinking about how can we make this technology globally available in collaboration with UNICEF. Thank you very much.
Thank you, Lara. Now I'd like to welcome our second speaker, Tanya Vasylyeva. Tanya is an expert in molecular and socio-behavioral epidemiology with a particular focus on HIV epidemics in migrant and forcibly displaced populations. Her work is aimed at utilizing phylodynamics and epidemiological modeling to describe the spread of viral infectious diseases in a population and assess different prevention strategies.
Thank you, Aaron. As Aaron mentioned, I work in social, behavioral, and molecular epidemiology. What that means is I use social network analysis and methods like phylogenetics, phylodynamics, phylogeography to describe how chronic viral infections, such as HIV and hepatitis C virus, moves in populations affected by displacement. Specifically, I'm working in settings that we call, that are affected by so-called big events. Big events are military crisis, environmental disasters, economic crisis. These are normally the settings where genomic capacities are pretty low. So we've been using Oxford nanopore technologies to obtain sequences and reconstruct phylogenetic trees, like the one pictured here, to assess when and where transmissions happen in displaced populations. Currently, my projects involve working with people at risk and living with HIV in Ukraine, such as people who inject drugs, men who have sex with men, and also looking at populations displaced to Colombia from Venezuela. What we do, we assess transmission clusters, and we estimate the time of their origination. We then reference them to the migration journey that people experience, and we try to use this information to advocate for a faster delivery of HIV prevention services in situations of protracted displacement. Thank you.
Thank you, Tatiana. Excellent. Our final panel member for the session is Anthony Hendricks. Anthony is a molecular microbiologist, researcher, and national coordinator of antimicrobial-resistant surveillance in the Netherlands. He is a PhD supervisor, national focal contact point for AMR, and is active in the field of public health genomics at the National Institute of Public Health and the Environment.
All right, thank you very much, Aaron. I hope you can hear me. So in the Netherlands, I hope you can see my slides. Yeah. In the Netherlands, we perform genomic surveillance on carbapenemase-producing Enterobacterales, Pseudomonas aeruginosa, carbapenem-resistant Acinetobacter baumannii, but also methicillin-resistant Staphylococcus aureus. For bacterial surveillance purposes, it is important to type fast, reliable, and to study outbreak and transmissions and resistance genes. It's essential for institutions to control their outbreaks. So back in the day, typing was performed by serotyping, phage typing, or antibiogram. And these methods have been replaced by pulse field gel electrophoresis, AFLP, but also multilocus VNTR repeat analysis like MLVA. These methods, the past 2 decades, have been phased out and shifted towards short-read sequencing-based typing of bacterial pathogens like SPA typing, multilocus sequence typing, whole genome multilocus sequence typing, and single nucleotide polymorphism typing. What you can appreciate from the figure is that the typing resolution has significantly increased over the years, and now we include complete genomes. However, it's expensive, laborious, and time-consuming. In the Netherlands nowadays, we focus more on nanopore long-read sequencing and aim to phase out short-read sequencing for genomic surveillance purposes. So in a recent study we performed, we sequenced almost 200 multi-drug resistant organisms by long-read sequencing, and we demonstrated that these organisms could be typed by in silico MLVA for Staph aureus, multilocus sequence typing, but also whole genome multilocus sequence typing, but very high accuracy comparable to short-read sequencing. Also, based on long-read sequencing only, we were able to detect resistance genes and carbapenemase resistance genes with high sensitivity and high specificity. Also, we were able to analyze recurrent MRSA outbreak in 2023 based on long-read sequencing only. And what you can appreciate from the figure is that the green long-read sequenced only MRSA isolates are grouped together with their short-read sequencing counterparts. So currently, we are validating this work and working towards an ISO 15189 accreditation for the long-read sequencing-based only genomic surveillance of multi-drug resistant organisms. And with this, I would like to thank you very much and give the floor to Aaron.
Thank you so much.
Yep.
Great, Anthony. So this is fantastic. I think it really paints a picture of the different techniques and strategies that can be implemented across public health using genomics. So with that, I'll open it up to the floor. Do we have any questions to dive into from the audience? Please.
Hi, thank you so much for your presentations. It's very interesting to see how you're applying the technology for public health. And I was wondering, for your talk, Antonio, for using in silico MLVA versus something like a core genome or whole genome MLST, what advantage do you have with using in silico MLVA, and can you only do that with long-read technology?
Yeah, it's a very good question, because our aim is to use whole genome MLST or SNP-based typing. Currently in the Netherlands, we perform laboratory-based MLVA. So, and we report that back to the laboratories and hospitals. So in the Netherlands, we're used to work with MLVA, but it's an outdated typing technique, and we are able to reconstruct MLVAs from long-read sequencing data, but I expect in the future we will definitely phase out MLVA because of the low resolution and continue to whole genome MLST SNP-based typing on long-read sequencing only data.
Thank you for the question. Do you have another? Yes, up front here.
Hi, I just wondered what the links were like with the people who actually implement interventions based on your data, and are those connections good? Is it well received, and just shed a bit more light on that?
Yeah, maybe.
Go ahead.
Yes, so maybe I can start it. Yes, I think for us it's like really important to actually like directly collaborate with the people who take the decisions in the clinical context. Obviously, directly compare our approaches with like what is currently the like clinically established methods, right? So I think like also in all sorts of other applications, especially in One Health, that's something sometimes a little bit complex in that you have like a lot of different like interested stakeholders there. But I think it's like really important to bring like all the different sides together. And if this is now from the clinical, from the conservation, from wildlife, you know, like fields and so on. So I think like part of our work is really to collaborate with all these people to bring the same language together. I do think that like a big shortcoming is just that we actually, right, like to actually come to recommending policy, we do still have to discuss a lot of the results that we are getting right now before we can actually say, yes, this is how retrospectively we would have recommended you to change policy. But I think that that's why it's so important that right now in our research we are collaborating closely. But I think you would have liked to say something.
We wouldn't be able to do any work without collaborations with people on the ground. People at risk and living with HIV often are stigmatized, and these are hard to reach populations. We need trusted partners, community-based organizations that have been working with these people for years to be able to recruit them into studies, including working with clinical professionals who can refer their patients into our studies. The problem is a little bit what we discussed earlier, that a lot of the time if we work with medical professionals, they want to use the data that we produce for clinical decision making, because in research limited settings, a lot of the time they don't have access to other drug resistance testing, for example. But we cannot normally communicate the results to them. And that creates a little bit of disconnect that we're trying to overcome. In terms of communicating our findings and results, often it is through roundtables, working with, again, community-based organizations, non-governmental organizations on the ground who can use and implement what we find to, let's say, recruit more people from certain populations, or think about how to distribute existing prevention services into the groups that might be more at risk. So we're trying to do that. Working with governmental organizations are normally a little bit more challenging.
Anthony, any thought on that as well?
Yeah, so I'm from the National Institute of Public Health in the Netherlands, so we are the center of the country, literally, performing genomic surveillance. So that's always retrospective. We look at trends in resistance, trends in hypervirulent Klebsiella pneumoniae, for instance, coming up, or decreasing pathogens. We do not interfere with patient diagnostics. And that's a very important separation we have in the Netherlands. So the hospitals themselves perform diagnosis of patients. Then we get the isolates and perform genomic surveillance. And that works well, and we report sequence data back. Laboratories can do their own research. So we collaborate a lot. 50 medical microbiology labs in the Netherlands. I think it's going really great. Some labs are using the data more than other labs. Some labs and hospitals are sequencing themselves a lot, and then we can provide, like, for instance, resistance plasmids, so they can analyze their own local outbreaks. So I think in the Netherlands, well organized, great collaborations, and they love long-read sequencing data as well.
And so obviously this doesn't end at the sequencing data. There are lots of stakeholders and partnerships that need to be involved in this process going forward. So thank you for the question. I'm sure there were others, and I think we could go on for longer, but unfortunately we've run out of time. But I would like to give a huge thank you to our expert panel, Lara, Tanya, and Antony. Can we have one more big round of applause for them? And please do come up to them after the fact and chat some more. With that, I would just like to say that this is the last session for day 2 of London Calling. It will be starting very soon, so please make your way over to the auditorium when you have a moment, and thank you all so much.